Good afternoon. I am Natasha Yoakley in Family and Community Medicine at Meharry Medical College, Program Director of Joint Interdisciplinary Programs, Tennessee AHEC and Maternal Health. This afternoon, the Primary Care Community Prevention Track in Maternal Health at Meharry Medical College will present Dr. Cornelia Graves, who will speak on hypertensive disorders and cardiovascular disease during pregnancy. Dr. Graves is a graduate of Baylor University, where she received honors. Dr. Graves received her medical degree from the University of Arkansas for Medical Sciences and was recipient of the Purdue Frederick Award for Excellence in Women's Health Care. She completed her internship and residency at Vanderbilt University Medical Center. She completed maternal fetal fellowship at Vanderbilt University. During her fellowship, Dr. Graves received special training in obstetrical critical care and became the director of one of the first critical care obstetrical units in the nation. She is previously a former division director of maternal fetal medicine at Vanderbilt University, as well as assistant dean for diversity. She is currently the medical director of Tennessee Maternal Fetal Medicine and the medical director for perinatal services at St. Thomas Health Systems. She is a professor at the University of Tennessee and serves as adjunct professor for Vanderbilt University and Meharry Medical College. Dr. Graves was the first African-American woman in the Department of Obstetrics and Gynecology, the first African-American president of House Staff Council, the first African-American woman to be promoted to senior academic status, and the first African-American woman to direct a major division at Vanderbilt University. Considered an international expert in the management of maternal disease, Dr. Graves is extensively published and has received numerous teaching, research, professional, and community awards. She has been actively involved in research and has served as an investigator on studies involving asthma, hypertension, preeclampsia, HIV, diabetes, and drug addiction during pregnancy. She is an immediate past member of the board of directors of the Society of Maternal Fetal Medicine. She serves as a physician advisor to the Preeclampsia Foundation and as a peer reviewer for SMFM, the American Journal of Obstetrics and Gynecology, AJOG MFM, and AJOG Global Reports. Dr. Graves has been instrumental in the formation of a maternal mortality review committee for the state of Tennessee and currently serves as a member of the review committee and a member of the CDC Committee on Bias in Maternal Mortality. She serves as the project leader for the maternal section of TIPQC. In 2012, Dr. Graves, along with Dr. Stacy Davis, a cardiologist, started the Collective Perinatal Cardiac Center, a joint venture between Tennessee Maternal Fetal Medicine and St. Thomas Health, which is one of the first in the nation to address maternal heart care from the preconception period through postpartum care with a focus of long-term provision. In her spare time, I don't know how she has any, but Dr. Graves serves as a keyboardist and choir director for her church and works with the youth ministry. We are pleased and so proud today to present Dr. Cornelia Graves. Dr. Graves, thank you for being here.
You're welcome. Good afternoon, everybody. And I'm hoping in this time, after that long introduction, that we're going to talk about hypertensive disorders and cardiovascular disease during pregnancy. I will tell you that hypertensive disorders and cardiovascular disease are where my passions are, along with diabetes. It is where I got my start in maternal fetal medicine. And so today I'm hoping we will be able to talk a little bit about the relationship and why it's important. I have nothing to disclose for this presentation. So we're going to talk about the physiologic changes in pregnancy, the impact of high blood pressure or hypertension and cardiovascular disease on maternal death, define the appropriate screening and diagnosis in patients with hypertension and cardiovascular disease, and then follow up with preventative care in the population. And as I know, there are doctors and health, community health persons and people who are interested in public health. I hope that we will cover all of those for you. So why are we so concerned about preeclampsia and cardiovascular disease? In this is the PBS NewsHour in 2021, it showed that maternal deaths have risen in the United States. Now, much of this has to do with the fact that of COVID, and we know that COVID had a big impact on pregnancy mortality. But also, when you look at the data throughout the state of Tennessee, COVID impacted us as well as some other things. And one of the things we know about COVID, not only was it the disease itself, but it was a lack of access to care during COVID that caused problems. If you look at maternal mortality by race across the United States in 2021, for non-Hispanic white women, it was 26.6 per 100,000, Hispanic 28 per 100,000. But if you look for Black women, it was almost 70 per 100,000. So our total rate was 32 per 100,000, which means that African-American women were almost 3 times more likely to die in pregnancy than their non-Hispanic white counterparts. And then if you look at maternal mortality by age, women over 40, the risk of death is 138.5 per 100,000 for especially versus women under 25, which is 20.4 per 100,000. So we know as the demographics of our pregnancy population change and we see more women over 40, this also impacts our maternal mortality rate. But if you add being Black and being over 40 in this country, if you add being Black and over 40 in this country, then the risk of dying during pregnancy is somewhere between 282 to 300 per 100,000. So when you talk about it from that perspective, if it's that much, then we have to really think about think about what we're doing. More importantly, that means that Black women can deliver more safely in Rwanda or the Congo than in the United States. Let me go back, I'm sorry. And if we look at maternal mortality by state, you can see there are about 3 or 4 states that are worse than Tennessee, but not too many. And in fact, this was 2021, but Tennessee's actually gone up in 2022 to where we're number 4 in the country for maternal mortality. And that means we have somewhere between 30 to 40 per 100,000 live births. So we need to think about what we're doing in the state. And you can see that the pregnancy-associated maternal mortality ratio in Tennessee went up significantly. It had actually gone down in 2019. It almost doubled in 2020. And if we go over here and we look, you will see that Tennessee is number 4, Arkansas, 40 per 100,000, Kentucky, Alabama, and then Tennessee. We are worse than the Mississippi, which we all know. So we can't even say thank God for Mississippi anymore. We really need to be paying attention. And what are the causes in the state of Tennessee? Non-Hispanic Black women, 2.5 times more likely to die. 89% of these deaths were deemed preventable, with 24% having a good chance of being prevented. Obesity, mental health, but look at the leading cause of deaths. Cardiovascular and coronary artery disease, including preeclampsia, followed by hemorrhage, and then mental health conditions and substance use disorder. So how does pregnancy change the way the heart works? We're going to talk a little bit about cardiovascular physiology. Blood volume increases by about 30 to 50%, and so does cardiac output. This begins at about the first trimester, 7 weeks, and peaks at 20 to 24 weeks gestation. Heart rate increases 10 to 20%, and systemic vascular resistance is reduced by 30%. What does this mean? This means that your blood volume can increase and your heart rate can increase, but your blood pressure actually can decrease early in the pregnancy. Pregnancy is what we call a hypercoagulable state, which means you're more likely to clot. which is very valuable when you deliver. And then during labor and delivery, cardiac output fluctuates greatly, somewhere between 6 to 12, and I've seen as high as 15 liters per minute with a contraction, because during a contraction, the heart has to be able to mount a response to perfuse the placenta. So if you look at our hemodynamic parameters, cardiac output goes up, blood volume goes up, heart rate, and stroke volume. This is the third trimester here, right in the middle. You can see the increase. But I want to point out to you something. Hemodynamic parameters just don't go back to normal when the uterus goes back down. I always tell people the 6 weeks mark is so that people, that the uterus is in the pelvis. In the Western world, that means you can go back to work. But your cardiovascular volume and your cardiac output linger until almost up to 6 months. And that's something we're going to keep in mind as we move forward. Also, if you're doing any types of testing, there is some left ventricular shortening, which means that, of course, the heart is more full. You get some pericardial effusions and mitral regurg because of this increased cardiac output. And every day, somebody tells me their EKG is abnormal, but it's not. In pregnancy, there are things that happen with the EKG, such as the axis shifts to the left. There's these Q waves in T and with T wave inversion and leads 3 in AVF. So what happens to those of us who are doctors on the line, we'll get this call that our patient has a, quote, anterior MI, which is a heart attack of unknown significance. No, they're just pregnancy, and this is a normal pregnant, and this is a normal pregnant EKG. Blood pressure begins to fall as early as the 2nd and 3rd trimester with return to baseline. Then blood pressure also is influenced by positioning. It is less when the patient's on her side. Now, back in the day, you would send your patient to labor and delivery, and they would say, well, your patient's blood pressure is better on her side. Great. Can we send her out that way? No, we cannot. So that's something to be thinking about. So that is something that we need to understand. We don't take blood pressures on the side. We take them the way we would normally take them in someone who's not pregnant. And if you put a patient at bed rest, their blood pressures may be improved. But the caveat is patients with high blood pressure will exhibit a greater percentage or a drop in blood pressure. And if we look at the study, what we know is we know that blood pressure progressively will dip a little bit at about middle gestation, and then heart rate progressively increases. So blood pressure dips just a little bit, heart rate progressively increases in pregnancy. So look at the blood pressure means in changes in patients with high blood pressure, though. You can see that we can miss this diagnosis, especially if the patient presents at 17, 20, and then 25. So at around 29 to 32 weeks, the blood pressure begins to go back up, and that's when the diagnosis is made. So these patients may actually have chronic, may have a high blood pressure, but we're not able to delineate that. And why is this an issue? Because the placenta is a vascular organ. The placenta is connected to the umbilical cord, but if the placenta cannot implant well, these maternal spiral arteries and this junction here, there's not good blood exchange and not good oxygen exchange. And over time, what we will see is that the manifestations of poor placental function, baby not growing well, high blood pressure, sometimes feedback on the heart, and feedback on other organs as well. So let's talk about hypertensive disorders in pregnancy. They complicate about 5 to 8% of all pregnancies. Some days for me, I feel like they're 100% of all pregnancies. 76,000 maternal deaths worldwide. Why? Delay in seeking care, delay in diagnosis, and delay in treatment. And this is a true story. Just the other night, I got called and they said, we have this new protocol. Do you really want to use it? Yeah, I do. And the protocol required that the blood pressures be checked more often. But, basically they were trying to, say, well, her blood pressures are normal now. But preeclampsia is a vasospastic disease. It also accounts for about 500,000 infant deaths, which we forget because we have to deliver these patients early. Hypertensive disorders have increased by about 1 in 4 since 1987, and it's a leading driver of maternal mortality and morbidity, as we see even in the state of Tennessee. And racial and ethnic disparities, of course, dominate treatment and outcome in these patients. So as I said, it's about 7% in the United States, often in women who've had pre-pregnancy, in women with pregnancy-related high blood pressure, not as often as we sometimes think in patients with chronic high blood pressure or people who present to pregnancy with a diagnosis at that time. Now, how do we classify high blood pressure in pregnancy? Preeclampsia, proteinuria is not required with or without severe features. And what are severe features? Headache, visual changes, abnormal labs, blood pressure that is higher than we would like, with a top number of 160, bottom number of 110. And so you don't have to have all of those features to have severe preeclampsia. Then there's chronic hypertension. That is, you came with blood pressure issues. Chronic hypertension with superimposed preeclampsia and gestational hypertension. Now, until recently, we thought that we should not treat stage 2 hypertension. But when the CHAP study came out, what the CHAP study showed is treatment of blood pressure greater than 140/90 delayed the onset of preeclampsia and reduced the risk of an early delivery. So it is now recommended that we treat stage 2 hypertension. And in some patients, I treat stage 1 hypertension, especially those patients like with lupus or heart disease or other things, diabetes, that already can compromise their heart and their other vasculature. So keep in mind now that we are treating stage 2 hypertension in pregnancy, which is a change probably from the last time we talked about this due to the CHAP study. Chronic hypertension persists more than 42 days postpartum. It's associated with preeclampsia. And like I said, the value of antihypertensives for stage 1 is being debated, but for stage 2, there's no longer a debate. So we need to be treating these patients. So what are the risks of chronic hypertension and hypertension in general? Stroke, myocardial infarction, preeclampsia, and then of course, fetal complications, including growth restriction and stillbirth. So how do we work up patients' baseline? You want to get your liver functions, your kidney function. You also want to get a protein or know where the patient's protein normally lies. And then we want to treat hypertension as a pre-cardiovascular disease. What does this mean? We want to work them up as if they had some underlying level of high blood pressure. Of heart disease, because we know that these are all now related. And a pregnancy is a cardiovascular stressor. We just talked about that. So we need to know if the patient has any other underlying problems. Gestational hypertension is new onset prior to 20 weeks gestation. It is blood pressures of greater or equal to 140/90, 4 hours apart, and no proteinuria. Doctors love gestational hypertension, but what people need to know is more than 50% of these women will develop preeclampsia, and it's definitely the truth if they develop, quote, gestational hypertension prior to 32 weeks. New onset hypertension is after 20 weeks, 140/90, 2 separate occasions. Proteinuria is for the diagnosis of preeclampsia or edema and weight gain, like the patient has gained in 10 or 12 pounds, or in the absence of proteinuria, the patient's not making urine, that's the renal, headache, neurological, epigastric pain, that is the HELLP syndrome, which is a hematologic disease, pulmonary edema, leaky capillaries. Preeclampsia is a multi-system vascular disease. Severe features: blood pressure greater than 160/110 at least 6 hours apart, or the patient's at bed rest, or two blood pressures that are in this range within 1 hour. So when a patient comes in, she gets on she gets her blood pressure taken. It's 160 over 110. The next blood pressure 15 minutes later is 130 over 80. That doesn't mean that you stop taking blood pressures, because preeclampsia is a vasospastic disease. So 15 minutes later, her next blood pressure is 170 over 120. At that point, the diagnosis of severe preeclampsia is made. And who's at risk? Patients who have with their first baby, preeclampsia in a previous pregnancy, patients with those vascular diseases that we talked about, including kidney disease and autoimmune disease, obesity, which is a pro-inflammatory state, women over 35, assisted reproductive technology because of the fact they often have abnormal placentas. And then one of the things we often don't think about, but obstructive sleep apnea. When we take blood pressures, as I said, not on their left side, they need to be seated, or they can be in the bed with their legs flatted, preferably, bare arm, resting 10 to 15 minutes. If it's still elevated, then you don't need to reposition the patient to another side. And this is just making sure that you have the appropriate cuff size. It makes all the difference in the world. I have patients all the time say, well, come to your office, my blood pressure is normal, but in my doctor's office it's high. And that's because their doctor's office doesn't use a large enough cuff. So all of these things are important in evaluating high blood pressure. Well, I love this mnemonic about preeclampsia. Preeclampsia is about that defective spiral artery that we talked about. Because the patient already had abnormal vasculature, it could not implant appropriately. The placenta begins to have hypoperfusion. And basically, I tell people that preeclampsia sends out these pro-inflammatory proteins to make sure that it gets perfused. So it makes your blood pressure go up. That helps to perfuse the placenta. It's not about blood pressure. It's about that placenta. It makes your blood thin. Maybe that'll help. It makes you excrete some protein in your urine, because then that makes your blood a little thinner, changes how things perfuse across the membrane. Maybe that'll help. It's all about your placenta. So patients always need to be educated that preeclampsia is a serious disease. This is from the Preeclampsia Foundation. And basically, it tells the patient, these are the things you need to know about: stomach pain, nauseous and throwing up, swelling in your hands, seeing spots, and gaining 5 more pounds. You should call your provider, because these are we have to educate our patients, because often by the time the patient presents to us, there are complications that may be hard to fix. There's significant maternal morbidity with hypertension and preeclampsia. You can see stroke, kidney failure, pulmonary edema, and often mortality. And we see this often in patients, especially when they're older. Stroke is rare, but 13% mortality risk, more common in pregnant women than in the non-pregnant population. Why? Those stroke volumes that we talked about, and that increased blood volume hitting against vessels. And when does stroke happen? And most maternal deaths, 2 days to 6 weeks post-delivery. 12 times higher. Women with preeclampsia are more likely to have a stroke. Now, there's a hypertensive emergency is a blood pressure of 160 or greater, 2 readings at least 15 minutes apart for 1 hour. Or a diastolic, 2 readings 15 minutes apart over 1 hour. Doesn't have to be consecutive. But if you know then you promptly treat patients and improve the outcomes. And that's not with an epidural, that's with medication. You want to prevent end organ damage, avoid a seizure, and returning that blood pressure back to normal is not the goal. Because remember, the placenta wants its perfusion. So the goal is to keep the mother out of trouble. We use magnesium sulfate for neuroprophylaxis. And I want to point out for those who do take care of patients, it does not matter if your patient has a diagnosis of preeclampsia or gestational hypertension. The diagnosis is the hypertension, and magnesium should be used for maternal neuroprophylaxis to prevent seizure. Now, one of the things and one of the reasons we're probably talking about this is I want to point out that the definitions of hypertensive urgency are different depending on what your discipline is. So I want you to look. Most definitions are 180 over 120. And if you send your patient to the emergency room with a blood pressure of 160 over 110, you know what they do? They give them blood pressure medicine and send them out. So that's one of the reasons we see such significant maternal morbidity and mortality in this area, in the area of hypertension, because it's not just about our OB people knowing from a public health standpoint, but it's about everybody who touches a pregnant woman knowing that these are our guidelines. What happened? Let me go back. Okay, so there are protocols, and I'm just gonna go over these just to remind people that we have protocols, and these protocols are in hospitals or should be in every hospital to treat high blood pressure. And we use 3 medications: labetalol, hydralazine, and then my favorite, oral nifedipine, because it can be given without an IV. The goal is to drop the blood pressure back below 160 over 110. And when pregnant women present or postpartum women present to the ED, the goal is not to treat them and send them home. All these patients need to be admitted for further care. In patients who have a hypertensive emergency, we may need to go to the ICU, which is something that people may not be aware of. And we may need to give IV blood pressure medications. Again, preeclampsia should be considered a critical event. It's critical that we take care of this patient immediately. Otherwise, we're going to get ourselves into trouble. This is just the onset of action. I want to remind people that this is why the protocols are built the way they are and why there's different time limits for different medications, because the onset of action is not the same for every medication. So what are our delivery recommendations? Gestational hypertension, 37 weeks. Chronic hypertension, 37 to 39. Preeclampsia without severe features, 37. And with severe features, 34 or at the time of accelerating disease. So if your patient comes in and she's 32 weeks and I can't get her blood pressure down, she's having a baby. So what are the complications of uncontrolled hypertension? Maternal death. Black women in one study were 3 times more likely to die in the hospital with an increased risk of stroke and cardiac failure. And in that same study, Black women were also more likely to have a higher rate of stillbirth. Hopefully with the new preeclampsia test, which I did not include in this particular lecture, but I find fascinating, we will be able to figure out how to make this situation better for all women. And it's not over. Black women were more likely to have postpartum follow-up appropriately with increasing maternal mortality. And then intraconception care, you know, that 1 year after we have, this is where policy impacts us, where we can see that patient who has TennCare, that is everything. Because if we don't see that patient and we don't counsel her and we don't tell her about her risk of cardiac disease, she's going to come back and we're going to have the same issues we had before. So you're asking, Dr. Graves, cardiac disease, what is the relationship? So I just told you that, that patients with preeclampsia are more likely to have heart failure. Well, then the American Heart Association came out and showed that numerous studies link preeclampsia to cardiovascular disease. And it increased the risk 2 to 4 times. So it said that preeclampsia really is a failed cardiac stress test, which means these patients should be seen for long-term follow-up. And then there was a hallmark study out of Kaiser Permanente, 1,400,000 women, 481 were preeclampsia, 266 of these women died from a coronary artery disease at some point. There was an independent risk factor for subsequent coronary cardiovascular death. For early preeclampsia, it was almost 10 times higher than the general population. And I love this graph because these are normal people. These are with people with preeclampsia by 34 weeks. See, they're about 10 years out, you start having complications and death. But look at preeclampsia by 34 weeks. Death starts as early as about a year out. So there is a definite connection between preeclampsia and heart disease and preeclampsia and heart disease. So then the American Heart Association said that these guidelines, women with preeclampsia should be regularly evaluated and treated for cardiovascular risk factors such as blood pressure, obesity, smoking, and high cholesterol. And screening for risk factors should start within 1 year after delivery. Pregnant women with high blood pressure who experience high blood pressure during their pregnancy should talk to their healthcare providers about low-dose aspirin starting in the second trimester until delivery to lower preeclampsia risk. Now, what strikes me is the American Heart Association is now telling us, hey, this is a heart disease, and we need to be much more involved in making sure patients understand it's a heart disease. And we need to also talk to patients about prevention, which I find fascinating. And if you look at maternal mortality, which we've kind of already reviewed, I just want to remind you that 1 in 3 pregnancy deaths occur within 1 week of delivery. What I want to get to is what those deaths are from. I showed you Tennessee's data. This is out of Illinois. This is in 2013. You will see where it's going up: heart disease, cardiomyopathy. This is from 2017 from the CDC. Again, heart disease, cardiomyopathy significantly increased in this population, with the percentage of deaths continue to rise, very much consistent with the data that we see here in the state of Tennessee. So Briller et al. Published this in 2017. Again, this is out of the state of Illinois. 22% of their deaths were from heart disease. And unlike what we think, it's not the people who are born with it, it's the people who acquire it. 97% had acquired heart disease, cardiomyopathy, hypertensive cardiomyopathies, hypertensive heart disease, myocardial infarctions. Of those diseases, 28% were cardiomyopathy, 13% were hypertensive disorders, 11% were arrhythmias, and 9% were coronary artery disease. And I think what we need to do is change our mindset that, oh, well, I'm taking care of a young woman, her arteries are just fine. Just recently, I took care of somebody who had a history of Crohn's, type 1 diabetes, and some other things. And when I got a CT scan to look at something in her abdomen, the CT scan came back coronary artery disease. And this is a 33-year-old woman, because she's had type 2 diabetes for a long time. See, these diseases are all related. And when we treat these patients as if they are not going to have complications because they're young and are able to have children, that's why our maternal mortality rate is so high. Now, this is from the California Collaborative, 2.1 million live births. This is in 2005, 25% cardiac disease, 63% cardiomyopathy. Again, we're seeing these opportunities for improvement in this particular population. Many of these patients who have a preeclampsia prior to delivery. I reviewed a chart of a patient who had obviously had hypertensive disease. She was allowed to continue her pregnancy to 40 weeks. Then she got heart failure. Then her heart failure wasn't well managed, and then she died. We have to start seeing this as a continuum. Again, this is in 2018, the leading causes of maternal death. And again, this is the Tennessee data. Why do we miss cardiovascular disease in pregnancy? Because it looks like so much of the things that our patients complain about. I don't feel good. I'm short of breath. I'm having palpitations. My legs are swollen. Yes, I know it's 116 degrees in Nashville. Everyone's legs are swollen. But there are some things that we need to pay attention to. When my patient tells me she's short of breath on more than one occasion, I'm like, she's mentioned that twice now. I need to really pay attention. She's having chest pain. That's not normal. Her heart She has palpitations on a regular. That's not normal. Her heart rate's above about 120. That's not normal. She then has swelling in her hands or her face. That's not normal. Those things are not normal, and we need to recognize them as not normal. So there's a cardiovascular screening tool for which I've been pleased to participate in. And what we've done is looked at things that may increase the risk of cardiovascular disease and screen women when they come in and present. Shortness of breath, orthopnea. You shouldn't have to sleep on 3 pillows when you're pregnant. Asthma that's not responsive to therapy. I've had 2 patients I've diagnosed with heart disease and they kept on getting inhalers. Chest pain, people who continue to have dizziness and fall out. Their blood pressure greater than or equal to 140/90. Their SATs are less than 96. Their BMI is greater than 35. They're greater than 40. They have high blood pressure. They're African American and probably Native, indigenous, and substance abuse disorder, and a history of chemotherapy. These patients need to be worked up because you can see that being hypertensive is a risk factor for having heart disease. Now, they also need patient education. So here we are, symptoms to watch for in late pregnancy: extreme swelling, extreme fatigue, fainting, cough, chest pain, or shortness of breath. We cannot just say, oh, well, these are, don't worry about these. And guess what? A lot of these also overlap with people who have hypertension. A lot of preeclamptics present with extreme swelling, or they present with chest pain because their blood pressure is really high, or shortness of breath because their blood pressure is really high. So we want these patients to come in and to be seen. If you've had heart disease, you're over 40, again, over 40. If you've had preeclampsia before, if you're African American, and if you're obese, we've got to continue to add these risk factors up. And we have to train our emergency physicians about how to take better care of these patients. So in 2018, Dr. Davis and I wrote an article for Circulation about these cardiovascular complications in pregnancy. And what we really want to do is advocate for changes in taking care of women and not make pregnancy some part of a isolated event. And that's kind of what we do in this country. Oh, great, she had a baby. And we don't see the patient again until she has another one. Or the patient had a baby and had preeclampsia, she was traumatized, had PTSD, and we see her back when she's 53 and heart failure. We cannot continue to look at these pregnancy complications as isolated events. We should train primary care providers and cardiologists in taking care of pregnant women because most of them are not trained. And in fact, when I work with a cardiologist, I need to make sure they have some idea of pregnancy physiology and hemodynamics, which is significantly different than very much significantly different than a normal adult, other adult hemodynamics. And then we have to develop teams. So because medical silos are no longer acceptable if we're going to reduce maternal morbidity and mortality. And that's one of the things we really need to be thinking about. So I wanted to talk to you just a little bit about how this looks. This is population complicated with preeclampsia, and I'm going to show you some other diseases and vascular dysfunction. This is our healthy population. With no intervention, by the time they're middle-aged, here they are. This is the threshold for vascular and metabolic disease. They're way over. But what if we use pregnancy as a time for targeted screening, lifestyle modification, and an early treatment? We could even out that curve to make it such that these women who are at risk actually have a modified risk and a risk very close to that of the general population. And people should really be interested in this because if we talk about preventative care and saving money and healthcare costs, this is where we need to be looking. So Dr. Davis and I looked at developing a cardio obstetrics program. And I will say that the cardio obstetrics program that we have here at St. Thomas Midtown is one of the first in the nation that starts at preconception and talks about the risk to our patients, and then goes all the way through to talk about the risk of preeclampsia and long-term and long-term issues associated with preeclampsia. And I'm going to show you the other things that are associated with heart disease as well. So what is the challenge? We have few evidence-based recommendations that address cardiovascular health in pregnant women. When this lack of guidance is combined with inadequate understanding of maternal physiology and the associated adverse pregnancy outcome, it really complicates the management of pregnancy, because what you may do in a pregnant woman could, and a non-pregnant woman could really be very detrimental in pregnancy. And without the absence of clear guidelines, it also leads us to over and under counsel patients about outcomes. So there's no guideline. You come in, and I've had this happen many a times where some other discipline has told the patient she shouldn't continue her pregnancy and she needs to not be pregnant anymore. Really? Based on what data? And how did we score her out? And this is a whole nother lecture, or patients who have, especially preeclampsia, who are traumatized, who really want to be counseled, hey, will this happen again? And will the same things happen again? So we have some suggested improvements. We need to have care from preconception to 1 year postpartum, especially in these patients with adverse pregnancy outcomes. And one of the things in a public health standpoint, we need to understand the importance of lactation in future cardiovascular disease. Lactation, I'm probably a little bit of a egghead scientist, but lactation just reminds me of so much of how divinely we are designed. Did you know that when you lactate, you improve your cardiovascular health? And that in patients who have elevated, and in pregnancy, you elevate your low density lipoproteins, which is your bad cholesterol, to make hormones. Well, in lactation, you increase your high density lipoproteins, which are what you need to have improved cardiovascular health. So it's like lactation actually undoes what pregnancy did. It also improves the risk of decreases the risk of breast cancer, and it also decreases the risk of obesity and future diabetes. Again, because of all the things it does to kind of reverse some of the effects of pregnancy. And I think this is where we need to make a bigger impact on our patients about what they can do to avoid future disease processes and future disease, and what they can do to reduce their risk in a future pregnancy. Improvements in education. We don't have any standardized education programs between our body and the American College of Cardiology. And one of the things we really need to talk about is how do we decrease disparities and inequities. We have to understand social drivers. But we also know that for Black and Brown women, it is not social drivers, because they often have access to care. They often are seeing a provider, but often they're unheard. And I was on a session with the Preeclampsia Foundation with one of the activist groups in Washington, D.C. And it was the mother of one of the CDC researchers who died from congestive heart failure after preeclampsia, who'd only gone to the emergency room 7 times. So we have to address bias. How are women heard? How are Black and Brown women heard? They're there. I know you've had a baby. I know you're stressed, anxiety. We have to integrate that history. Did you have preeclampsia during your pregnancy? Did you have any other things that may make me think that you're at risk for cardiac disease? And improve research participation. We also need to create and sustain collaborative models of care. So one of the things I want to talk about when you develop a comprehensive center for cardiovascular disease, it is not just high blood pressure that increases the increased risk of cardiovascular disease in pregnancy lifetime. Cardiovascular disease over a lifetime. We have all these markers. High blood pressure, probably the most. Gestational diabetes, just read an article that even a failed 1-hour GTT is associated with an increased risk of having an abnormal calcium score. Heart disease. Placental abruption also increases your risk of cardiovascular disease. Growth restriction and miscarriage, people who have continued fetal loss, and preterm birth. And the reason is because all of these are about endothelial dysfunction, vascular dysfunction, and then inflammation and vasospasm. There's a great article in the New England Journal of Medicine on obesity and pregnancy. If you have a subscription, if not, if you email, I can send it out to and it can be disseminated. But it talks a lot about obesity and how it causes all this inflammation. And so all of those things have to be taken into consideration. And what I have found in taking care of these women is that, yes, they're at risk for high blood pressure. I have so many patients who have abnormal lipid studies, and then, of course, increased insulin resistance. So this is our collaborative approach. We want to talk about maternal mortality and morbidity in these patients, even who have a history of hypertension, preeclampsia, or pre-existing heart disease, understand the environment, allowing patients to become pregnant without understanding risk can lead to significant challenges, because if you have underlying heart disease and I tell you, hey, you may have to be admitted to the hospital and stay from 24 weeks on, that's something people have to wrap their heads around. We discuss medications, and we also talk about the risk of recurrence. If you have preeclampsia before 34 weeks, the risk of recurrence is 25%. And then some of these have genetic markers as well. Antenatal care, screening for cardiovascular risk, even without a previous diagnosis, as I've shown in this lecture. Intrapartum management, delivery at an appropriate center of care, maternal levels with a multidisciplinary team approach. And then postpartum management, with a focus on lactation care, as we've talked about, counseling for long-term cardiovascular risk, and a focus on preventative care. So I wanted to leave a few minutes for questions, and so I just want to close with some key points. Hypertensive disease and cardiovascular disease are the leading causes of maternal morbidity and mortality. Prompt treatment of hypertension can reduce serious complications for the mother in the immediate. Early screening for heart disease can also decrease maternal morbidity and mortality. We need to still continue to have this special recognition of the physiologic changes in pregnancy, which will assist us in improving care in our pregnancy population. We should see pregnancy in the postpartum period as a window for opportunity to identify risk factors and institute a program for preventative management. And then last but not least, adverse pregnancy outcomes, including hypertensive disease, increase the risk of future cardiovascular disease. And we need to be able to expand our bandwidth to be able to counsel these women appropriately, not in the postpartum period, and then make a plan should they decide to have another pregnancy. I think that's all the slides I have, and I'm happy to take any of your questions. I was seeing there were a number in the some things in the chat as we went. And so I'd be happy to take any of your questions regarding preeclampsia, heart disease, and hypertension in pregnancy.
For those that have questions, please unmute and ask your questions for Dr. Graves. Thank you.
No questions?
I see a hand up.
Hello, this is Dr. Britt from Meharry.
Yes.
So Dr. Graves, thank you for the information. How do we, from a community stance, share and advocate for awareness of these definitely health conditions that we see present in many women of color?
So one of the things that when we had a grant, we actually did a poster, and it's this in many of our offices. And what it says is, if you have these conditions in pregnancy, you're at increased risk, or you've had these conditions in the past, you're at increased risk for having complications in heart disease. So what you need to do, or what would be great, is to tell your provider, so we can go ahead and recognize that you have those increased risks and do the appropriate workup. So that's one way. A second way is one of the things that we're going to be doing throughout the state of Tennessee as we launch the cardiovascular bundle, which is educating patients. Dr. Danielle Tate has come up with an acronym called HEARTS, and we're going to be educating patients very much on those things I was talking about, those warning signs. When to present to your doctor, when not to take a no. Say, I'm not leaving, or I'm going to go to another place, another hospital, until they make sure that I have the type of care that I need. Thinking of somebody presenting to an ED 7 times and being ignored and finally dying, who's a CDC researcher with a PhD, should be sobering for all of us. So we really have to empower patients and those who advocate for patients to make sure that the patients are being heard and getting the appropriate workup. So it's not just educating patients, but it's educating all of this is going to be a big task, because I don't think that most people realize that heart disease is the leading killer of pregnant women.
Thank you. Thank you for sharing.
Dr. Graves, this is Hannah Dudney. I have a question. When we reach out to our primary care colleagues and they are learning more that, preeclampsia should be considered like a failed stress test, and it should be treated as having a cardiovascular condition. When a primary care colleague has a patient that says, I have a history of preeclampsia, what can we point them to say, this is how you should manage that patient kind of going forward? Should you treat this patient in the same kind of risk category as somebody that, is there something similar that they are already treating that they can use as an equivalent, or kind of what should their further evaluation be?
So one of the things, that's a great question, Dr. Dudney. And one of the things I think what people need to understand is preeclampsia, in my mind, is a manifestation of some part of metabolic syndrome. So, and of course, I'm working to get my data together, but and I'm looking to maybe even do calcium scoring in patients with a history of preeclampsia to see if we can determine those women who we need to follow more closely. But I think we have to tell our colleagues that this is very much like metabolic syndrome, so they would need to follow them in the same way. They need a yearly glucose. They need to have yearly lipids. I cannot tell you the number of people I see in my postpartum preeclampsia clinic at 8 weeks, and their triglycerides are like 400, which is 4 times the value. And the people will say, well, that's because I had ate before I came in. No, unless you're eating lard straight, no one's triglycerides should be that high. So I think that we need to tell them they have to follow these patients very much like patients with metabolic syndrome, and then institute those therapies that they would institute, statins and things of that nature. A lot of times in people of childbearing age, we're afraid to institute certain medications. But as we grow into understanding preeclampsia, we also know that many of those medications, such as metformin and even a statin, can be continued in pregnancy.
Thank you. That was really helpful, because I often find, when we determine something like, preeclampsia is associated with cardiovascular disease, people that don't treat preeclampsia on a regular basis and don't see patients with preeclampsia, it is a challenge to decide, okay, how to manage these patients within our clinic. So that's helpful. Thank you.
Absolutely. And one of the reasons I'm really pushing people to develop a metabolic clinic for women. I think that our metabolic diseases are often overlooked because they don't present the same way. But these women need long-term follow-up support, lifestyle change, dietary modifications. And I feel if we had places for them to go that they felt comfortable, we would get better outcomes.
Dr. Graves, I'm going to read a question. This is Natasha that's in the chat. It says, beyond postpartum extension policies in states that have not extended, are there other legislative policies that could support this issue, not only in Tennessee, but in other states?
Medicaid expansion. I was just looking at the news yesterday. Since Roe v. Wade, birth rates are up 3% in Tennessee. Great. Except for one thing, we have a lot of maternity health deserts. And which means that these women aren't being delivered by obstetricians or don't have an OB, may not be being delivered by obstetricians and or other or even family practice people. Many of these women will drop in their nearest ED and have a baby because that's the closest thing to them. And so we really need to be looking at our healthcare deserts because we know that the emergency room is not the place for pregnant and postpartum women to present. It is one of our goals, hopefully, to educate our ED providers and to provide some ED. I'm working in my institution right now to see how easy and hard it's going to be, but to provide them with the same screening tools that we use in our OBED. And to provide them with for women of childbearing age, asking the question, have you been pregnant in the last 6 months or last year, would be very helpful in identifying those at risk. But if we could expand Medicaid and open up some of our smaller hospitals. In fact, the news article went on to say that because of this, many of our hospitals are being stretched. And we know that when we stretch resources, we're more likely to have outcomes that are untoward.
Okay, we have another question in the chat. Any suggestions on how to best develop a care coordination system that allows PCPs and OBs to meet patients' needs before, during, and after pregnancy?
So that's one of the other things that we're going to be looking at. And I think the other thing is that we have to realize that for some of these women, they need to be delivered in centers where there are people who specialize in taking care of patients, especially those with pre-existing heart disease. But it's a knowledge thing because if we, as I said, we don't even have guidelines. And so how do we give out guidelines if there are no clear guidelines to educate people? So we have to ourselves develop those guidelines and make our PCPs aware. If you have a patient with hypertension, or if you have a patient with a heart disease, that not only do you need to refer them, they need to be referred to their OB, but they need to have preconception counseling. So OBs who want to do that, or they need to. It's interesting to me that often people don't know what maternal fetal medicine specialists do. They just think we're high risk OBs, and so they send us a lot of PCPs will send me people to deliver, and I'm like, that's not what I don't even, I can deliver, but my concentration is on something else. And so I think helping our PCPs understand how we as OBs work and how we have specialists as well, it would be extremely helpful to helping coordinate care. And then after pregnancy, making sure these people get back into the system for their postpartum follow-up, especially those who have preeclampsia and hypertensive disease. We have a system in which the patient sees us. They come back to see, because many of these patients have been seeing me in the MFM office anyway. And then I refer them to the cardiologist. And so there's a seamless care, because once they see me, that referral is automatically generated. And then there was a question about what article did I reference? Are you talking about the obesity article, Tamara?
Yes, that's the one. Yes.
Okay. I'm going to put it in the chat.
Thank you, Dr. Carter. There's another question in the chat. To piggyback on the previous question, do you see a place for community-based health workers such as doulas in the care coordination and especially in preventive strategies?
Absolutely. Doulas are really important in especially making sure that patients understand the seriousness of what is going on. So often what I find is patients, diabetics or whatever, and especially in our communities, it's almost as if, well, my mama had diabetes, she died at 35. My grandmother had diabetes, she died and so they really don't know that they can take their disease process and they can improve upon it. So making sure people know that this is not a hopeless situation, but this is an empowering situation is really important. Making sure they understand the role of everyone in the care team. And then, of course, doulas are very supportive in the postpartum period. Especially in breastfeeding and lactation, and explain to women why this is important. It's not just feeding your baby, it's taking care of you as well.
We have another question if you have time, Dr. Graves.
Yes, ma'am.
How can we advocate for coverage of these services for women, either by TennCare or by private plans?
Is this for doulas or for doula services?
Dr. Britt?
Yes.
Yeah.
So yes, we need to continue to, I think that again, in maternal mortality, the United States, our view of having a baby is just so baby centric. And I think a lot of times what happens is we're like, well, the baby was fine. Or the other thing I see so often for me, and I laugh at people and say these things. I said, they think that we are down here singing zippity doo dah, my oh my, what a wonderful day. And I just got finished running a code and now someone's hemorrhaging in room 2. We have got to make people understand that while pregnancy is natural, there are also dangerous times, and that as many people as we can have advocating for patients, it's going to reduce some of these dangerous times. Now, I do know that a couple of the systems, I believe Vanderbilt and Ascension, and maybe even HCA, provide volunteer doulas that are supported by the foundations, and so they pay for them in that way for people who cannot afford to pay for one themselves.
Thank you, Dr. Graves.
And I put the reference for that article, and it will make you think of obesity completely differently after you've read it.
Well, Dr. Graves, I believe this concludes the questions, the Q&A session. This has been very beneficial for me as a non-clinician, as just as a public health specialist. I believe we've had a very interprofessional and multidiscipline group on this call. And so that's always great. Thank you. We're getting a lot of great presentations, Dr. Graves. If there aren't any additional questions, this does conclude the session. Is there anything else that you would like to end with, Dr. Graves?
No, I think that it's going to take all of us, and
Okay.
I really believe in the public health setting. And so as we move forward, Dr. Tate and Dr. Wolf and I, we're going to be reaching out to those public health counterparts to help us educate and maybe some innovative ways to think about educating people. One of the things I said to somebody, I said, I really think that we need to be doing TikTok. Everybody does TikTok. That everybody's scanning Instagram. How do we get the message out to those people? Because that's their, we may watch the evening news, but they're watching, they're watching YouTube. How do we get the message out in an age in which media is much more varied? And so we'll be reaching out to you guys to help us think about that.
Wonderful. Thank you, Dr. Graves.
Well, I'm going to go back and see patients, and I hope everyone has a great day.
Thank you. I will be reaching out to you, Dr. Graves.
All right, that sounds great. I'll be looking forward to hearing from you.
Okay, take care.
Bye-bye.
Bye-bye.